In your slide boxes, M1001, hypertrophy uterus, M1005, squamous metaplasia cervix, M1004, that's a condyloma lesion, condyloma acuminata. It's labeled in your slide boxes as apoptosis skin, but that's a squamous papilloma with coilocytosis, so that's condyloma acuminata. M1007 is atrophy of the uterus. M10012 is labeled as simple hyperplasia, but actually it is an endometrial polyp, so that's a mislabeling. M1023 is proliferative endometrium, and M1037 as well as M1087 are both leiomyomas. So let's start with the normal uterus. This is what you're seeing in your screen right now. It's made up of interlacing fascicles of smooth muscle cells. So the leiomyocytes are fusiform or spindle-shaped with elongated nuclei centrally located. It is disposed into bundles that intersect, or fascicles that intersect in 90-degree angles. The stroma, or the connective tissue pasting all the cells together, is fibrovascular in nature. If you have a hormonal stimulation such as progesterone in the state of pregnancy, this will stimulate the endometrium as well as the myometrial fibers, or the smooth muscles, to undergo hypertrophy and hyperplasia. So the smooth muscles also undergo hypertrophy and hyperplasia. Hypertrophy is the enlargement of the cell, and hyperplasia is the increase in the number of cells. So during pregnancy, if you have a corpus luteum of pregnancy in the ovary, you will have residualization of the endometrium, and in the myometrium, such as seen in slide number M1001, you will see enlargement of the cells and numerous cells comprising the myometrium itself. And that's why the uterus becomes bigger and the myometrial walls become thicker during the state of pregnancy. That's M1001. Let's go to the second slide in your slide boxes. I don't have M1004, so let's immediately go to M1007. M1007 likewise shows the uterus, however, it is focused on the cervix uteri rather than the body of the uterus, or the corpus uteri. Nasa yung M1007. Ay, hindi pala. I'm so sorry. M1007 also entails the body of the uterus, and it's focused on the myometrium. In the postmenopausal state, you don't have the corresponding spikes of estrogen and progesterone already. So what happens is that the uterus is not stimulated, the endometrium as well as the myometrium. So what you're looking at in the microscope right now is the endometrium, and on the left side of the the screen is the myometrium. Let's go to the endometrium. If the case is that you don't have stimulation of progesterone and estrogen, look at this, the endometrial glands seen here. You have smaller endometrial glands. Some of them are cystically dilated, and some of them will be lined of bicuboidal cells instead of tall columnar cells. Likewise, the stroma of the endometrium becomes fibrous, not the usual embryonal type of stroma. It becomes fibrous. Overall, the endometrium becomes thinned out. This is what you call senile cystic atrophy of the endometrium. Okay? So the usual cause is loss of stimulation, hormonal stimulation. So you might be able to have this if you are postmenopausal or if your ovaries have been surgically removed or you have undergone oophorectomy bilateral. Likewise, the cause of this will be seen in the blood supply shown in the myometrium. As you know, in the older ages, because of the diet and lack of exercise, there's a tendency for the body to accumulate nasa kabila ng slide. Normal. Yeah. There's a tendency of the blood vessels to have atherosclerosis. And thus, you will have thickening of the blood vessels. This also happens in the uterine blood supply as well as the ovarian blood supply. If this is the case, you will have atherosclerosis or thickening of the tunica media of the blood vessels in atrophic, causing further atrophy of both the endometrium and the myometrium. So we have here a blood vessel, and surrounding it will be your myometrial fibers. The myometrial fibers likewise show a tendency to become smaller and lesser in number. Accompanying it will be fibrosis of the interstitial stroma. So you can see lots of collagen bundles in this particular slide. Kahit yung daliri mo. So let's go now to the slide number M1005. M1005 is a slide of the cervix uterine. So, the cervix, as taught to you in histology, have two parts. You have the ectocervix, there, lined by stratified squamous epithelium. The ectocervix will not have any glands. And near the ectocervix, you have the squamo-columnar junction. There. Okay. Squamo-columnar junction wherein you have a sudden change from stratified squamous epithelium to tall columnar cells with basally oriented nuclei, and these tall columnar cells secrete mucin. That squamo-columnar junction from the joins the ectocervix and the endocervix. The endocervix is lined again by tall columnar cells with basally oriented nuclei. The endocervix is the one with endocervical crypts. It is commonly called as endocervical glands. So when you see endocervical glands or crypts, you are already in the endocervix and you are not in the ectocervix. Okay. That is the normal lining as focused in the screen of endocervical crypts and the endocervix. They're like the lining of what you reviewed a while ago in mucinous cyst and mucinous cystadenoma, correct? If you have an abnormal stimulus such as uterine prolapse or repeated infection in that area, the endocervical lining epithelium will be so irritated it will decide on another course. First, the basal cells of the endocervical epithelium will decide not to become endocervical cells and instead multiply themselves. Thus, you have what you call reserved cell hyperplasia, and this is seen on the screen right now. You still have remnants of the endocervical cells atop the hyperplastic reserved cells, as being pointed in the teeny-weeny arrow by Dr. De La Rosa. Okay. If this matures, if the reserved cell hyperplastic tissue matures, they would like to transfer to another type of epithelium, specifically stratified squamous cells, which is known to be resistant to friction and other mechanical trauma. So, you will see areas where endocervical crypts are lined not by tall columnar cells, but by stratified squamous epithelium as seen in this particular view of the slide. That's an endocervical crypt, and it is lined by stratified squamous epithelium. If this happens, you have squamous metaplasia of the cervix. Next, we have M1012, labeled in your slide boxes as simple hyperplasia. However, on focusing, you already see a change of the stroma to fibrous tissue and sclerotic blood vessels. So focus now are sclerotic blood vessels, mainly seen in the middle. Those are sclerotic blood vessels. Okay. And they are admixed with endometrial glands of varying sizes. Okay? The stroma becomes very fibrous, especially near the sclerotic blood vessels. And these three characteristics, varicized endometrial glands, sclerotic blood vessel groups, and fibrosis of the stroma, leads you to a diagnosis of endometrial polyp. That's slide number 12, labeled as simple hyperplasia, but actually it's an endometrial polyp. So in your practical exams, if you see groups of sclerotic blood vessels, check if there are endometrial glands and check if you have fibrosis of the stroma, and that will be an endometrial polyp. Let's go to slide number 23. slide number 23 simply shows you a normal endomyometrium. Okay, let's go back to histology. You have the myometrium. Okay, and the junction of the endometrium and the myometrium. Seen there. The myometrium is made up of smooth muscles and the endometrium. In the endometrium, you have two layers. Remember histology. The part which is in close approximation with the myometrium is called the basal endometrium. Okay? You will see spiral arterioles. In some areas, and you will see, and this is not responding to any of the hormonal changes happening in the body. So the endometrium, the basal part, is not responding to any of the hormonal changes. It remains basal. Only in states of pregnancy does it undergo decidualization. Before that, it will not change with the hormonal stimulation. The thing that changes with hormonal stimulation is what you call the functioning part of the endometrium, and that is the red topmost part seen in the slides right now. That's on your left side. Look at the endometrial glands in that part. The endometrial glands coming from the base, going up the superficial portion, or the functioning endometrium, are relatively straight and tubular and round. Okay, that's seen there. On higher magnification, the glands will be lined by columnar cells, which are pseudostratified, and you may even see mitotic figures. Okay? That is because the cells in these glands are also proliferating. Likewise, the endometrial stroma, which is known as your embryonal type of connective tissue, seen here, does not show any decidual change. So it seems as if they don't have cytoplasms. Okay? This is a proliferative endometrium. Let's go to slide number 37 and slide number 87. We'll just show you one slide. The slides will show you basically the histology of smooth muscles seen with the myometrium. If you are, did you see the gross specimen? They are labeled outside, so you can look at them anytime. Maybe after your exams or tomorrow morning. I know, not tomorrow, on Thursday or on Friday. Because they may come out during the exams, practical exams. Okay. If your tumor is made up or composed of interlacing fascicles of smooth muscle cells, fusiform cells with centrally located elongated nuclei, and it is seen in the myometrium, that will be a leiomyoma. That's the most common site of developing leiomyomas. What is the difference between a leiomyoma and its malignant counterpart? Leiomyosarcoma will have coagulation necrosis. increased mitotic activity, hypercellularity, cellular atypia, which we do not see here. So this is a benign lesion. That's a leiomyoma. Okay, we are through with the slide box. I also have to show you some of the slides which may come out during your practical examinations. So what organ am I showing? You see swirls of fibrous tissue or fibroblast supported by a vascular stroma. So those are fibroblasts in sphere cyanoplication. Please, especially at the periphery, not near the blood vessels. Wow.
Sure zero na naman yung prescription. Wala pa ako makakisa.
So if you are shown something like this, that's the the ovary. Okay, this is ovarian tissue. If you see something like this, what are these? These are granulosa cells which has been luteinized. So it's a cluster or a fascicle or groups of or nests of granulosa cells which has been luteinized. And as a result of luteinization, the granulosa cells will have plump pink cytoplasm and a round nucleus, which you don't usually see. Luteinization of the granulosa cells signals that this ovary has undergone ovulation and it has already released an ovum. This is a corpus luteum. If you are going to be asked, what is the phase of the endometrium? And this is the one focused in, as a picture from the ovary. What is the answer? The answer is secretory phase. Okay? Because you will only have a corpus luteum if you have undergone ovulation, and after ovulation, that's already the secretory phase. Absence of corpus luteum, anong ginagawa ng endometrium? The answer is proliferative phase, kasi hindi pa siya nag-ovulate. Okay? Next. Let's go back to the endometrium.
Exam na lang, napilayad pa. Ano ba kasi hinahabol-habol mo at nahulog ka?
Again here, the endometrium shows you, the functional endometrium shows you tubular glands pointing right up in the superficial portion. Higher magnification will still show you that these glands are lined by pseudostratified columnar epithelium, some of them showing to you mitotic figures and apoptotic figures. The stroma is unremarkable with no pink cytoplasm, none. It's as if you don't have any cytoplasm at all in the endometrial stromal cells. So this is still proliferative endometrium. Comparing that to the next slide, this was taken from a DNC, or dilatation and curettage. And you see endometrial tissue fragments. Focus on the glandular lining epithelium. The glandular lining epithelium shows you subnuclear vacuolations, and it is causing the upliftment of some of the nuclei. Some of the cells likewise show supranuclear vacuolation. Subnuclear vacuolations are the first clue that you have undergone ovulation, or the ovum has been released into the fallopian tube. So you see this about 36 hours after the ovulation. So when will you see this in the menstrual cycle? You will see this at around day 16 to day 17. Okay? When you see this in the practical exams and you see subnuclear vacuolations, that is happening in the secretory days, day 16 or day 17. If you look at the ovary of this type of endometrium, you will see a corpus luteum. A fresh corpus luteum kasi kakalabas na ng ovum. Next.
Window of implantation.
Still on the endometrium. This patient usually presents with abnormal uterine bleeding. And on dilatation and curettage, this is the type of endometrial histology you will see. What are you looking at right now? You see vari-sized endometrial glands irregularly distributed in a cellular endometrial stroma. Okay? That's the architecture. It looks like a Swiss cheese pattern. Yung kinakagat ng mga daga sa cartoons. Swiss cheese. Okay? Higher magnification shows you that these glands are still lined by cells showing polarity. Focus on the nuclei of the cells lining the epithelium. Lining the epithelium. Lining the glands. Okay. The cells, normal epithelium of the glandular lining, that's a good gland, will show you ovoid nuclei perpendicularly approximated with the basement membrane of the glands. So what you're seeing here are ovoid nuclei which are pointing towards the lumen with their base perpendicularly approximated with the basement membrane of the glands. That is normal. If you see rounding of the nucleus, that is atypia. That's the first sign of first sign of atypia. So this is normal. You don't see any hyperchromasia, or rounding of the nuclei. This is simple hyperplasia without atypia. If you see atypia or rounding of the nuclei and hyperchromasia of the nuclei, that's simple hyperplasia because of the architecture. Galit-galit yung mga irregular size na endometrial glands. With atypia this time because you see nuclear atypia in the lining epithelium of the glands. Okay? Next. Comparing that to this type of endometrium. Okay, this type of endometrium shows you irregular shape and irregular size glands arranged in a compact position. So, lab na lab nila isa't isa, kaya magkakatabi talaga sila. Konti lang yung stroma in between. Okay? If you look at the lining epithelium, this is what you call complex hyperplasia. Okay? Because of the architecture. Different sizes of glands, tapos magkakatabi talaga. Compactly arranged in glands mo. That's complex hyperplasia. Now the big question is, does this have atypia or not? The same is true with what I've told you before. So you see here elongated nuclei, perpendicularly arranged against the basement membrane. So you don't have atypia in these glands. If you're shown this, that's complex hyperplasia without atypia. But look at the other areas in this particular slide. You will see hyperchromasia. Look at the lining epithelium on this side. If this is the one being focused, especially these cells here and those cells over there, okay, you can see hyperchromasia and increased nucleocytoplasmic ratio in the cells, as well as rounding of the nuclei in some areas, and that is complex hyperplasia as for the architecture, and it is showing you atypia. That's complex hyperplasia with atypia. Same slide, but the ones without the rounding of the nucleus, hyperchromasia, and etc. That's complex hyperplasia because of the architecture na dikit-dikit yung glands mo, without atypia. Ito, pag ito yung nakafocus, tapos naiitim na yung nucleus mo, iba-iba na yung size and shape niya, that's complex hyperplasia with atypia. Okay? The one which is most commonly the precursor of malignancy is complex with atypia, followed by simple with atypia, followed by complex without, and then you have simple without. Next. Let's go back to the ovary. This may be asked in both the male genital tract and the female genital tract. It has the same histology. So look for the clinical history. It will show you germ cells in nests and irregularly distributed. And the germ cell nest will be traversed by fibrous stroma. So these are the germ cells. These are the germ cells. Where is the fibrostroma? Those are the fibrostroma. Look at the fibrostroma on higher magnification. So aside from the germ cells and the fibrostroma, you will see lymphocytes in the fibrostroma. So those are lymphocytes. Ito mo naman, lymphocytes. Yung mas maliit. Those are the lymphocytes in the fibrostroma. What do you have in this slide? Germ cells. Germ cells. A fibrostroma, which is punctuated by lymphocytes. If seen in the testicle, the diagnosis is seminoma. If seen in the ovary, the diagnosis is germinoma. Another ovarian tumor. Lower magnification will show you columns of cells of this particular portion, and you will recall them as the ones lining your ovarian follicles. Okay? These are actually granulosa cells which has formed itself into tumors. Higher magnification shows you this type of architecture, and that is the Col-X nervani. Okay? This tumor secretes estrogen. So if you have this tumor in the ovary, chances are you have a simple hyperplasia or a complex hyperplasia in the endometrium. So those are called exner bodies, and these are granulosa cells. This is a granulosa cell tumor. Okay? Likewise, review condyloma acuminata. I think I have shown you all that I have shown the other section. You may use this as your study room, but please keep quiet.